My name's Damien Smith. My NHS works at Hillingdon NHS Trust. We work on both sites, Hillingdon and Mount Vernon. I work privately at Bishopswood. I'm a consultant anaesthetist, but I'm actually the lead for the pain service at Hillingdon. And that's my real passion and what I'm involved in. I was asked to talk about the medical management of acute back pain. Now that is a massive topic, and I've got 15 to 20 minutes to get through it, so it's going to be a bit of a romp, okay? And there'll be lots of slides flashing up. Once we have our kind of speed dating type session, you'll be able to ask me some questions then. If you just pick up a couple of things, hopefully a couple of resources or a couple of ideas, that'd be really good. But you see so many of these patients on the front line before they get to us. I'm just going to give you a timeline about guidelines and back pain guidelines and why I'm talking about what I'm going to talk about. So NICE was formed in 1999. Then they came up with a very sexy titled CG88, which was published in 2009. And what that was the NICE guidelines for non-specific lower back pain. This caused a lot of consternation and arguments in the pain world. There was no consultant in pain medicine who was on the panel. I have an example of the, have you got this? I have an example of some of the parts here, and that says do not offer TENS, do not offer radio frequency facet denervation. Do not offer injection of therapeutic substance into the back for non-specific lower back pain. Now this has all changed, and what I'm going to talk about today and my colleague's going to talk about is early diagnosis, early treatment, early intervention will hopefully stop these acute backs from becoming chronic backs, because once they become chronic, then they're a lot more difficult to treat. Following the NICE CG88, the Professor Watson, who was the president of the British Pain Society, he was a physio by trade, he was forced to resign. And then last year, the British Pain Society came up with guidelines, the Map of Medicine, which is funded by the NHS Institute for Innovation and Improvement, came up with the Map of Medicine guidelines, and NICE have actually scrapped, or in the process of scrapping, the lower back pain guidelines, and they are being rewritten. These are the three documents that I use for the talk today. This is the British Pain Society and the Royal College of GPs about implementing patient pathways and commissioning. This is what the British Pain Society guideline looks like. It's very busy, as on the Map of Medicine one. This section here is for the GPs, and this section here is for the secondary care units. The guideline I'm going to mainly use is this one. This is the Map of Medicine Lower Back Pain General Management. Now this is just a guideline. How we can actually go through with these, I'm not really sure. Seeing people in 2 weeks, getting them physio straight away, getting them acupuncture straight away. It's not really realistic, but this is what is being put out there as the current guideline. Some background information. As you know, 70 to 84% of all adults will experience lower back pain in their lifetime. The most likely cause of lower back pain is this 90% group, depending on what you read, 90%, 95%, used to be called non-specific lower back pain, is now called simple musculoskeletal pain. Certainly the patients, when I see these tend to be the facet joint pains, the sacroiliac pains, the disc pains, and these other things. But there's a difference of opinion about what to call them. The big thing, or the thing that we'll talk about today, are red flags, and keeping an eye out for red flags, spotting red flags, and what investigations to do. So patients with low back pain, prognosis of these lower back pains, 70% of them will return back to work after 1 week. 90% of these low back pains will return back to work within 2 months. So the ones that get referred on to myself and my clinic are the 10%, the ones that don't. And expect and educate the patient and explain to the patient that there is a high recurrence of back pain, and it's not uncommon that they get another episode within a year. So this 2 to 7% will become chronic, and these are the cohort that take up a lot of the spend on lower back pain. And if we can get the acute back pains early, if we can treat them early, hopefully we can stop them becoming chronic. The risk, I'm going to explain to you the risks of developing back pain, the risks of not treating the back pain. The risk of developing lower back pain is same posture for long periods of time, lifting heavy objects, twisting, bending, obesity, operating heavy machinery which causes whole body vibration. Risks for delayed return to work will be behavioural, socioeconomic and occupational. And then the complications, if we don't treat these patients early, is they're more likely to go on to develop chronic pain, they're more likely to become depressed, loss of employment, disability, and certainly become opioid dependent if they are used. These are some of the information resources out there. These are the information resources advised by the Map of Medicine and the British Pain Society for you to use, for you to explain to your patients. This is a web page about back pain on the BMI site. There is a government combined speciality group phrase here, which I'm going to tell you later on. This is patient.co.uk. We have another resource here, as you notice with some of these, they have helplines, they have talkbacks, they have forums, and these are things that we should explain to the patients and get them involved in. Again, here, Arthritis Care has a helpline team, someone to contact, and there'll be people in your area, so on and so forth. I'll just whiz through these now. National Osteoporosis Society. This is Action on Pain. Again, there's a section here about sciatica pain, TENS machine fundraising, support. All these tools are out there for patients, and the more we kind of get to know about these, the more we can kind of share with them. And this is another one called the Pain Toolkit. This is very much centered on self-management, education, reinforcing, pacing, goal setting, that kind of thing. Finally, the other sites include NHS Direct, NICE and the British Pain Society. And as I mentioned, advice, helplines, forums, local groups and patient information. You'll find that self-management, self-education, all these things are phrases that are being used nowadays in treatment of lower back pain. Some basic pharmacology information. It's okay to use strong opioids, but if it's only in the very early stages of an episode of acute back pain, if you're seeing the patient within the first 2 weeks, then it is okay to give them 5 days worth of a strong opioid. But when you are going to use strong opioids, you want to discuss the risks, the benefits, and agree a goal therapy beforehand. More and more places are now starting to use things called opioid contracts. This is an example of an opioid contract, but this is used in the chronic pain setting. It says, I understand that opioids are strong medication. I've been informed of the side effects. I know that they cause drowsiness. It's my responsibility. I agree to take this medication, not to change the amount of medication without discussing it with the doctor. I agree it'll be prescribed by only one doctor. I agreed to fill in my prescriptions at only one pharmacy. And it kind of ties them down. And if they break any of these issues, then you know that you may have a yellow flag situation on board. And then the second page is the patient signs it, you sign it, and it's dated. If the patient has a radiculopathy present, then what I'd urge you to do is add in an early anti-neuropathic agent, be that amitriptyline, pregabalin. And it's really important, this kind of rational polypharmacy. You'll find that you're using fewer, stronger opioids if you can mix in a polypharmacy situation. Useful websites for more pharmacology and pharmacy information are the UK Medicines Information website, the Royal Pharmaceutical Society, Primary Care Pharmacists Association, and Cardiff University have got a very good pain website called the Pain Community Centre. So now a bit about history, examination, investigations. When you see a patient with low back pain, what you're going to look for is red flags, and I'll go through a brief example of a red flag, and then to work out if the pain is mainly back dominant or leg dominant. If the pain's kind of back dominant, then it can often get referred into buttocks and thighs, but when we talk about pain being leg dominant, we're talking about pain that shoots down the leg, normally below the knee, into the ankle or into the foot. And also a thing to screen for is the risk of a patient becoming chronic, and we have this thing called a start back tool. For those of you who haven't heard of it, it was invented at Keele University. It's a 6-item tool which stratifies a patient into low, medium or high risk of becoming permanently disabled with a pain. So the classic red flag would be cauda equina. The patient may present with urinary incontinence or fecal incontinence, retention, urgency, saddle anaesthesia, loss of tone, and or motor deficits. If you're looking at a patient who has back pain or leg pain, when you're looking for nerve root pain or leg pain or radicular pain, it's going to be the leg pain is worse. As I said before, it's normally below the level of the knee. There'll be straight leg raise positive between 30 and 70 degrees, and there'll be a slump test positive. They may have sensory or motor changes. Obviously, there's your straight leg raise positive. That's an example of a patient who's having a slump test. Red flags, and if I'm going to talk about red flags, we'll go through the common red flags and 3 things you'd need to know for each red flag. So, patient who has cauda equina, they may present with incontinence, saddle anesthesia or loss of tone. If you suspect a patient has cancer, then what you'd want to look out for is a previous history of cancer, weight loss or age older than 55. If you're concerned they may have an infection, if you're concerned the patient has an infection, there may be a history of a recent infection, they may be systemically unwell or have a fever. If you're concerned there's a fracture, then there may have been some recent trauma, a history of osteoporosis or a structural deformity. And for inflammatory disorders, they tend to be younger patients, sacroiliac buttock pain and typically morning stiffness. Consider red flags in the young and those who are immunocompromised. Lower back pain itself over the age of 55 is a very weak red flag. Acute lower back pain over the 70s is an indication, is a good red flag for an indication of an osteoporotic fracture. And lower back pain in the young, the under 16s as well. The map suggests that ESRs over 50 and PCVs less than 30 are a predictor of potential for the presence of cancer. Investigations, the first 3 are the same investigations for all of these red flags, are a full blood count, ESR, CRP. With the cancer concerns, you're going to do a PSA and myeloma screen. For an infection, you'll add in also an MRI, and we have MRIs throughout these. Now, what your relationship is with your radiology department or your ability to access MRIs, I don't know. Certainly if the patients come to us without them, then we're going to refer them on for one. Differentials which cause back pain. Cancer differentials could be cancer of the kidney, prostate, ovary. If a patient has a UTI, a pyelonephritis or PID, that can also present as low back pain. And these are the things like calculi, aneurysms, pancreatitis can be other causes of lower back pain not to miss out. Treatment plan. Avoid prolonged bed rest. Advise gentle exercise. Discuss the prognosis with the patient. Explain 70% go back to work. Explain 90% are back at work. Discuss the return to work. Institute this early. Self-management, patient education, using those resources that I explained to you, and use an appropriate pain relief. Just some pharmacology here, looking at the number needed to treat for paracetamol, 4.6, number needed to treat for codeine, 17. Put them together, cocodamol, the actual number needed to treat for cocodamol is 2.2. Tramoset, 2.6. I'm not a fan of tramadol, actually. I find patients freak out too much on it, but the non-steroidals have a number needed to treat between 2.5 and 2.7. If a patient has a radiculopathy, as I say, you're looking to use amitriptyline, pregabalin, gabapentin. Number needed to treat, depending on what you look at, depending on what you read, was between 3, 5, 6 for these drugs. Review the patient 2 weeks later. At your 2-week review, the patient's either improved or not. This is how I'm trying to rationalise the map of medicine, but if the patient's improved, whoops, that's pointed at me. If the patient's improved, then you're going to continue the management. I think early recognition and early referral of radicular pain which doesn't respond to treatment, you'll hopefully refer them onto your local pain unit or spinal unit for investigation and treatment. If the patient doesn't have radicular pain, has back pain which hasn't responded, then again you're going to screen for red flags, discuss the prognosis, explain that 70% go back to work after a week, 90% go back to work after 2 months, and then you're going to start to assess them with a start back tool, see what the risk of this persistent disability is. This was the quote from the BMI back pain webpage, which is from the government's Combined Speciality Advisory Group, which says it's recognised that early back pain treatment is the most practical, successful and cost-effective solution to back pain. Don't wait any longer. The quicker you're accurately diagnosed, the more effective and successful your treatment can be. And this is what we're finding, and this is why the old NICE guidelines were kind of controversial, as they didn't advise injection therapy in some of these patients. So the start back tool, as I mentioned, this was invented at Keele University. It originally was a 9-item questionnaire, and the patient would be stratified into low, medium or high risk. The majority of people now just use a 6-item tool. So this is the 6-item tool. There's 6 questions. My back pain has spread down my leg at some time. Agree, disagree. I've only walked short distances because of my back pain. In the last 2 weeks, I've dressed more slowly because of the back pain. I feel that my back pain is terrible. It's never going to get better. Yellow flag question there. In general, I've not enjoyed all things I used to enjoy. Anyway, you score this, and if a patient's got over 3, then they're at risk of developing a persistent disability. You want to get these to the physio, you want to get these biopsycho-socially assessed. Medium risk patients, you're advised to go to the physio, they get acupuncture 10s, and again a return to work plan and an exercise program. Patients who are at high risk need to potentially have some CBT, talk about sleep hygiene, relaxation, setting goals, pacing, and discussing beliefs, behaviours and anxieties. A classic example I use is you ask a patient, did you have physio? They say yes. You said, did the physio make it worse? They say yes. Then you explain to them, okay, I'll join a gym today, I'll go on all the weights machines, row machines, running machines, how will I feel the next day? And so, you feel really stiff and really awful. And you say, why is that? Oh, well, you're using muscles and stretching things you haven't used before and you're getting things to work. Yeah, so why is that different than your pain? So the pain you feel after physio, actually that might be because you're using things you haven't used for a while, you're stretching things you haven't stretched. It's this kind of challenge to these negative beliefs which they have. And again, the guideline says review again at 12 weeks. Just briefly talk about yellow flags and sleep. Patients show any of these, then they're at risk. These are the yellow flags. So if a patient believes that harm, activity or pain and activity are harmful, as I say, physio made it worse, low mood, withdrawal, if there's claim or compensation going on, problems at work, overprotective or underprotective family. A common thing patients talk about is pain waking me up at night. This is a normal hypnogram. So you say to the patient, what is the ideal night's sleep look like if you could draw it? So you say, this is them awake, and normally what they say is, a perfect night's sleep would be going from awake, down to sleep, staying asleep for 8 hours, and then waking up. That is not normal sleep. This is actually the hypnogram for normal sleep, and this is the hypnogram for all of us if we have normal sleep. And what we actually do is we lighten and then deepen, and then lighten and then deepen throughout the night. We actually lighten 2 or 3 times a night. That's completely normal. Whereas the patient will say, pain's waking me up at night. Well, actually, we all wake up at night slightly, but you're just waking up and your pain's there, and obviously that's what you're focusing up on. But the pain's not waking you up. It's about challenging these beliefs. As we say, you review the patient. Remember, 90% will go back to work. If there's no improvement after 12 weeks or so, then you should refer them on to a centre for a multidisciplinary assessment. I think the thing is, get the diagnosis right, you get the treatment right. If I see a patient with facet joint pain, which is unresponsive to treatment that you've instituted, then they may need a facet joint injection. If a patient's got nerve root pain, they need a nerve root injection. If a patient's got spinal canal stenosis, they need an epidural injection. So as we've seen by the advisory group, early diagnosis, early intervention, this is going to help you avoid the patients becoming chronic. To summarise, this was the Map of Medicine back pain guideline, which is out there on their website. I've tried to summarise it into this. History exam treatment, see them 2 weeks later. If they're no better and they've got a radiculopathy, think about referring them on. If the patient's no better, think about doing a start back and referring them on accordingly. Continue the treatment, and if you get to 12 weeks down the line, you've done everything and they haven't got better, then think about referring them on to one of our teams. I work at Bishopswood. I have clinics on a Friday. Thank you very much. That's my son, Sam. He's not always that cute. And then if any of you have got a smartphone with a laser reader, I'll just leave the next thing up because it just takes you to a link for a questionnaire. I'll hopefully speak to you on the tables later on. Thank you very much.